Excellent.
Okay.
Let's
Of course, I have to let people in and present. So,
get everybody in.
yeah, thank you guys for coming today. Just really quick, I have the agenda up, and I did put people's affiliation in there. So we do have members from Healthcare Authority, the jails, ArrayRx Steering Committee, and our MODA partners. I'm recording the meeting, so anybody, you can share it with anybody afterwards. We're not going to go around and do individual introductions again, since we did that last meeting. So William, Hayes, and I will be giving a presentation, then open it up for questions and discussion.
So my name is Mark Stern, and welcome to everybody. And thank you so much, Lita and William, for doing this. Just to set the stage for today, so we learned, and I'm a medical advisor to WASPIC, we learned over the last couple of months from both Lita and William about this really cool program, ArrayRx, that is run by the Healthcare Authority, and we'll hear more details about it. But it seemed like a wonderful opportunity for jails to be able to get medications at markedly reduced cost to what you may be getting currently. And this would be both for jails that have already have contracts with pharmacies through through their own healthcare vendor, through separately, but in any of those settings, this may be something very helpful. This is separate from buying bulk medications, which is something that we have talked about before in the context of MLUD. This is to get individual prescriptions from a local pharmacy. So hopefully this will be something that everybody will look at and find some benefit in it. And with that, Lita, I'm going to turn it back over to you and William.
Yeah, thank you, Mark. Thank you for setting that stage. This also first was raised in the re-entry advisory group, that there is an issue when a patient is released from jail and Medicaid has to be turned back on, that there's a gap in coverage. So I'm going to introduce you to ArrayRx. There we go. Okay. So our mission and vision, as an organization that was established by states, and I have to keep admitting people, to assist public sector purchasers of prescription drugs, the mission of ArrayRx is to provide high-value pharmacy solutions for public sector programs. Transparency and stewardship of tax dollars are our highest priorities. ArrayRx is made up of 3 states, Washington, Oregon, and Nevada. Nevada joined us this year and rolled out a discount card program for all Nevada residents, especially the uninsured. ArrayRx is open to local government, private sector businesses, labor organizations, and individuals. Participating programs, no matter what their size, benefit equally from the savings ArrayRx delivers. ArrayRx is the result of a commitment by the states of Oregon and Washington to collaborate to provide solutions to organizations grappling with an increasing cost for prescription drugs and the lack of transparency in the pharmaceutical supply chain. So the history of ArrayRx, in 2003 to 2005, the Oregon prescription drug program and Washington prescription drug programs were each established through separate legislative efforts. In 2006, the Northwest Prescription Drug Consortium was founded when Oregon and Washington prescription drug programs signed an interstate agreement to pool their prescription drug purchasing to lower drug costs. The consortium's goal is to deliver transparent prescription savings programs to meet the pharmacy needs for public entities. 2007, MODA Health, a comprehensive service provider, medical, dental, pharmacy benefit plans, and self-insured plans, which is located in Portland, Oregon, was selected through a competitive procurement to be the administrator for the consortium. MODA has been retained as the administrator through 3 competitive procurements. The most recent was in 2020 and started this year, 2022. The consortium has a history of listening to public sector purchasers and setting up pharmacy programs to serve their needs. In 2008, Labor and Industry needed drug rebates and a mail order pharmacy. The consortium set up an administrative services only rebate program, and Labor and Industry had access to the consortium mail order pharmacy. In 2014, Department of Corrections needed a cheaper way to purchase emergency medications than sending staff to the local pharmacy and paying retail prices. The consortium set up the voucher program to get Department of Corrections the discounted prices that the same discounted prices that the discount card receives. We've continued to make all of our services customizable, recognizing the unique needs of public sector purchasers. This year, 2022, we rebranded our name to ArrayRx, and this one name unifies the Oregon and Washington prescription drug programs, all member states, and all participating programs. The steering committee has expanded its mission to offer ArrayRx services to states and municipalities nationwide. Nevada joined this year, and today ArrayRx provides services to 1.2 million individuals enrolled in our various programs. Our procurement standards and process. Since 2006, ArrayRx has utilized the Oregon State contract and procurement process and standards to regularly and appropriately seek proposals from the open market. Our current contract with MODA beginning January 1st, 2022 is for 5 years and renewable up to 10 years. Washington and Oregon states oversee ArrayRx's procurement and subsequent contracting with ratification performed by each state's Department of Justice, or the AG here in Washington. These practices establish a high bar for procurement standards, which should put any participating program at ease. ArrayRx exercises continued governance over the services that are provided by our contract administrator. These are the ArrayRx operating principles, highlighting transparency through pass-through pricing, a fixed administrative fee, and comprehensive audit rights. ArrayRx services currently include pharmacy benefit management program, a discount card program, a voucher program, and Medicaid fee-for-service program. Today, we're going to focus on the voucher and discount card programs as solutions for the jails. These programs feature a wide selection of participating pharmacies, an average savings of 60% on prescription drugs, and detailed reporting. So we want to start by showing you a sample of savings on common used drugs. The average retail prices were taken from the GoodRx price check tool, and the ArrayRx prices were taken from the price check tool on ArrayRxCard.com, which is our discount card drug price tool. So the discount card program is a state-sponsored prescription drug discount card. It's available to any resident of a member state. There's no age, income, or citizenship requirements. There is no formulary. All FDA-approved drugs are eligible. Discount card users get the same negotiated drug prices as participating programs. The discounted price is paid by the user at the point of sale. It's free to sign up. We have quick online registration and an option to use a digital card saved to your phone, or you can print it out. The card cannot be used in combination with other health plans, for example, paying a copay. And I'm going to turn this presentation over to William to talk about the voucher program and his experiences.
Good afternoon, everybody. I'm William Hayes. I'm the Director of Pharmacy for the Washington State Department of Corrections. As Lita introduced earlier, ArrayRx, or formulated the consortium, created the voucher program for us to use to obtain prescription drugs for our patients for emergency need. Previously, we were utilizing this previously we were obtaining medications from local pharmacies at retail price, and the voucher program helped us to save some costs. But I will talk about that a little bit more later in the PowerPoint. The voucher program is a unique process that captures the discounts available in the discount card program. Using this innovative prescription drug purchasing program, the facilities, correctional agencies, jails, even the state hospitals that are part of the ArrayRx program will manage individual enrollment in the program, either through a process of enrollment directly into the program, or using a system of enrollment such as we use with our Omni system. They are able to determine their own coverage or formulary. They can choose which pharmacies they utilize. They also can receive invoices that list detail that they determine is necessary, whether that be twice a month or monthly. And that information is detailed to what they need to see. It can include information of pricing, patient information, drug information, quantities, whatever is needed can be tailored to your needs. And ultimately, the benefit is saving money at the pharmacy. Next page. This process is a continuity of care process. The first two steps are prescribing and dispensing. Your prescriber for your patients creates a prescription. The individual receives that prescription, whether it's at the jail or in Department of Corrections or at the state hospitals, whichever entity chooses this voucher program. The prescription can be given while they're inside as they're releasing, or in some cases we've seen after they've released. The facility either has to enroll them at that point or they're pre-enrolled. And then the voucher is used in whatever way your entity determines is appropriate. We actually primarily use it in corrections for use to pick up the prescriptions, but it also can be used as it is by the Oregon State Hospital for individuals who have released. The prescription is presented at a local pharmacy, and as Lita indicated, there are many pharmacies that are eligible to accept this. Basically, it's the same as the discount card program list of pharmacies. The pharmacy essentially uses that voucher to bill the same program, and the copay amount, or the amount of the price of the medication plus a small discount, plus a small administration fee, is billed back to the entity that owns the voucher program. The prescription is then dispensed to the person who is responsible for picking up the medication, and the information for that dispensing is sent back to the facility or the entity that owns the process. Next page. Next step in continuity of care is that invoicing and payment process. The information from the dispensing is submitted to the claims processor, who ultimately sends the payment information to the pharmacy, so that the pharmacy understands that they're going to be paid and indicates that the individual who's picking up the prescription does not have to pay a copay. The administrator receives the payment information, creates an invoice to the facility. For example, DOC receives bi-monthly, or actually twice a month, bill that we then submit payment to MODA for the prescriptions that we have picked up. We pay the invoice to MODA, and then MODA sends that payment back to the administrator who has processed the claim, and then ultimately they send the final payment back to the pharmacy so that the pharmacy receives reimbursement for dispensing that medication to the patient. ArrayRx also, through this program, has a rebate system set up through purchase of contracted prescriptions, where eligible claims are able to receive money back from the manufacturers for purchasing these specific contracted drugs. And 100% of those recovered rebates are returned to the program that purchased the drugs. DOC has, over the years, received money back from purchasing drugs from the for our patients from those eligible contracts. And it's just another way of saving money by participating in this program. Next. So just want to talk a little bit about how DOC has utilized the discount card, the voucher program, which is very similar to the discount card, but functions in a little bit different way. And then compare that to how the Oregon State Hospital uses it. So you can see a couple of examples of the options that you have in potential for choosing to use the voucher program. Our biggest problem, as I indicated earlier, and as Lita said, was we were sending our staff out to local retail pharmacies, or also working on contracts with certain local pharmacies that were facility specific. And those contracts were at the whim of the pharmacy that we were they're at the whim of the pharmacy that we were working with. And that was based on the price that they wanted to charge us. And sometimes that was at full retail price. Sometimes it wasn't. But we didn't have the power of a large group like ArrayRx.
In case I ever turn this thing on and I don't want that camera on, that will cover my base.
Could you please mute? It looks like Dina. Thank you. So we weren't able to take the large group power to negotiate down good prices, and the consortium at the time was able to utilize that same power with the discount card to give us the ability to access pricing. But we also had another challenge to solve, and that was when we centralized pharmacy, we needed to be able to access urgent medications because our central pharmacy had a turnaround time. And I understand that some of the jails also have pharmacy services from major pharmacies that are in other areas of the country that provide services that may not arrive timely. And you may also have patient care disruption issues that you need to have access to prescriptions a little bit quicker as well. So this voucher gave us the ability to continue to access those local pharmacies, but also to save money at the same time. The solution, as you see here, was that customized voucher program. With the administrator, MODA, and the consortium, we were able to set up a system that created an eligibility file from our Omni offender management system. Each of our patients who were incarcerated in our facilities were deemed eligible by the simple fact that they were located in our facilities. That file is sent over on a daily basis to the processor, and they are eligible at any moment while they are incarcerated to be able to receive medications when it's prescribed by one of our prescribers. We set certain limitations, a day supply limit. We decided that we didn't want refills to be authorized. A new prescription was determined to be required for each. We set a limitation on which drugs we would carry. We have essentially an open formulary, but we didn't want to cover over-the-counter drugs. We felt that we had a sufficient supply of urgent medications that were inclusive of some over-the-counter drugs that were available in our facilities. And we didn't want to have very high-cost medications automatically eligible. We set up an override system where if a patient needed something that was high cost, they needed to consult with me before we authorized that to be processed. Over time, we went from that emergency need use to finding that we needed to have some availability for medication supply upon release. We were finding that some of our patients were both releasing without medications, but also because of just the way that things happen in our system, patients were releasing, or we were finding that they were needing to be released at the last minute. So we wanted to be able to allow our facilities to obtain that 30 to 90-day supply of medications from a local pharmacy and not have to wait for our central pharmacy to supply it to them. So we increased our days supply limit so that those facilities can obtain a release supply from their local pharmacy when there was last minute need for a release supply. On occasion, we also find that our patients have released without medications, and we have a process set up where those patients can go with a community custody officer and pick up needed medications, but that requires a little bit of work with me or others to ensure that the staff member is present, because we still require a staff member to obtain medications for our patients. And the results that we've seen is we're able to ensure that our patients received continuous care with regard to medications. We have seen continuous savings, and we also have customized reporting. We receive those invoices twice a month, but we also requested data to be fed to us that we put into our centralized data warehouse for potential review, and our intent is to use that as part of our overall utilization of medication review processes to see how we're utilizing medications across the state as we continue to develop our formulary. So that's the DOC use. The second use is with the Oregon State Hospital. They too had some patient care disruptions and also cost issues. Theirs was a little bit different though. Theirs was essentially related to release. When their patients were releasing, they had difficulty providing medications to their patients upon release and ensuring that their patients had that continuity of care upon release from the Oregon State Hospital. The solution for them was also a customized voucher program, but their utilization was a little bit different. They wanted to provide the patients with a voucher that could be used to go to the pharmacy of their choice to pick up their needed release medications after they left the hospital, so that they could go pick up their medications and have them when they needed them at their home or at their release location. Their eligibility system was set up where the staff at the Oregon State Hospital utilized MODA's employer dashboard system. MODA has an internal system where their employee, they're able to log into a system and enter eligibility live. And it is set up so that the voucher is only set to be eligible for the time that the prescription is valid. So once the prescription is filled, the eligibility becomes null. So the patient gets a prescription for up to a 14-day supply with no refills. They take the prescription to a pharmacy. Once it's filled, their eligibility is turned off. They don't use it while the patient is at the facility, only when they release. They found that this helped to reduce waste because I failed to mention one of the things that they found when they were providing medications to their patients when they released was when they walked out the door, they would just throw it in the trash. They found it to be more successful if they gave the prescription to the patient, and if they chose to get their medications at a local pharmacy, they were more successful in obtaining it themselves. It helped them to manage costs, and it also empowered the patients to self-treat and to be more successful and reduce recidivism. So those are the two examples of success with the voucher program that we've had so far, and it's been a great program for both of these institutions. Our former steering committee member from the Oregon State Hospital that started this program there spoke highly of it, and I believe our current steering committee member from Oregon State Hospital is finding it to continue to be a good program for them as well.
Thank you, William. I think I'm going to pause and see if there's any questions right now before I go into my questions on the Medicaid gap coverage.
And I'm happy. Go ahead.
What if the patient needs more than 14 days to get to see their provider, which can be weeks, especially if it's psychiatric medications?
Mhm.
The eligibility can be set to whatever time frame that you want it to be set. The system, I go into the system very frequently, and you can actually set it to be valid for infinity. The challenge there is you also have to make sure that however you set it up, if you set it for infinity and you don't have that built-in process to turn off after that time frame and you're managing it manually, you have to ensure that you go back in and make the patient ineligible. So however you determine for your entity that when you work with MODA, if this is a program that you want to set up, you have to make sure that you set it up to be foolproof for the process that you want it to be.
So that still doesn't address my problem. So let's say we use the example of sertraline. The patient's given a voucher for 14 days or 30 days or whatever, and they leave, but they can't see a doctor for 10 weeks. So that means at the 1 month point, they're out of meds and now they don't have anything. What fills that gap?
So for us, I see what you're saying. For us in our setting, we have to work with our prescribers to see if there's comfort with prescribing another set of prescriptions. We updated our policy to prescribe up to 90 days supply, so that we try to build that, to bridge that gap. You know, we also have built, or we're starting to build a reentry process where we try to establish that connection as quickly as possible. And I know for the jails, that's it's going to be a lot harder because you don't have as large of a reach as corrections does, and your patients are not in, and it's just more challenging. I guess I'll just leave it at that. It's more challenging for you. So it's hard for me to say, because from our aspect with ArrayRx, we don't have the ability to give you that reentry aspect. That's not the role that we play. I mean, from my experience in working in corrections, I think what you in your setting need to do is find those community resources that can give the patient the ability to get another prescription. What we with ArrayRx can do is give you the access to have it covered, and then you and the jail can help the patient to get it paid for. The challenge that you're experiencing is getting a prescriber to be able to prescribe it. Now, if your prescribers are willing to hand the patient a 90-day supply, and that gets them to their next outpatient visit with a new prescriber, great. But we're not able to help with the reentry process.
And
I think
Troy,
a lot of prescribers are willing to give a 90-day supply of sertraline. I doubt they're going to give a 90-day supply of Adderall, for example.
Yeah, that's definitely one thing that I recognize. Yes.
And Troy, are your do you know, are these Medicaid eligible patients?
Yes.
So I would assume by 10 weeks, then Medicaid's turned back on. So then they wouldn't need
It
the
should be turned on
voucher.
the first day, but it's
There's a
so we
lag.
try to make appointments ahead of time. Let's say a resident has a GI problem and we want to get him back with a GI specialist. They often won't make appointments because their Medicaid isn't turned back on, so they won't do it until that's turned back on. So at that point, they're out of our hands.
Right.
Looks like Robert has his hand up.
Yeah, I'm with Moda. I'm one of the administrators. We're the administrator for this program. William is absolutely right in terms of how he described how DOC is set up, and of course how OSH is set up. But within the voucher program, you have a high degree of flexibility. It depends on kind of what you're willing to pay for in terms of the medication. But you could set it up to allow for 1, 2, 3, 4 refills, etc., and then it would terminate. So if you have a situation where somebody has a prescription for citrulline and it might take them 10 weeks to get on Medicaid, you could allow for open refills on that for a period of time. But of course, the risk is that they go in for a citrulline and they may be on Medicaid, but it would bill to you. So you have to be, have the ability to kind of turn off that eligibility once you know the individual is in Medicaid.
I think we may be talking about two different things. Troy, are you asking about that? Are you bringing up the point that your physicians may not be willing to write a prescription for that length of time?
Yes. So
Okay.
that's probably the thing. I guess I can't. Yes, I understand how this can help get the medications once you have a prescription, but it doesn't seem to answer how we get our young people to see a
Mhm.
provider in a reasonable amount of time. So
Got it.
when we have bounce backs and they come back and I say, hey, how come you didn't stay in your sertraline? I couldn't find anyone to prescribe it. Or it took so long that I went back to using marijuana. Or
Right.
those are some of the common things I hear.
Okay. Yeah, this unfortunately, this this whole thing that we're here for today isn't going to solve that problem. All it does is provide a mechanism for getting a prescription filled that has been written, but the writing part is not something that ArrayRx can help with.
Right.
Troy, I see now that you're with DCYF. Perhaps we can have you may be on the reentry group, but perhaps you can have some conversations with Brooke Amix, who wasn't able to join the call today, and we can have some, you might be able to have some discussions with our reentry process, and maybe as sister agencies discuss some of the positives that we're moving forward on in that aspect, because it's a thing that DOC has been working on for a long period of time, and we're starting to have some success with.
Sounds good.
Okay, so I wanted to go into some questions that I have about the Medicaid gap coverage. And these are questions that I've been thinking about since our last meeting and the reentry advisory group meetings. I want to better understand how the jails can use the voucher or discount card programs to solve the Medicaid gap coverage problem. And it might be necessary to take some of these questions to the reentry advisory group meeting where the managed care organizations and different HCA people are at to maybe help answer these. But I just want to put these out here now. So if the voucher is used for Medicaid patients and the discount card is used for non-Medicaid patients, and I say that because the voucher for DOC pays for those prescriptions used when picked up with the voucher. For jails, I was assuming that jails do not pay for medications once the person leaves the jail. So the voucher would be paid by the managed care organization because Medicaid is turned back on. There's just this lag of, the timing when the person's released, getting it put in the system, getting it put in the MCO system, et cetera, et cetera. So, the managed care organization would pay for the voucher. For those clients that are not Medicaid eligible, they could be signed up for a discount card to get a discount on their medication once they leave. But my question is, do jails know which patients are on Medicaid and which ones are not?
Does any of the jail administrators want to take that, Wendy or?
Yeah, I can take that, Doc. Chris Wee, Lewis County Jail. So I could just only speak for the jail here. We actually have a transition coordinator that tracks those that are on Medicaid, and he's also a navigator. So he also helps us reactivate them prior to and at time of release. So we get that information exchanged that way. So we are able to track those that actually have those benefits.
Okay, great.
There's probably,
so
go ahead.
So,
John.
Dr. Surfer, this is John McGrath from Westwick. So smaller facilities that don't have 24/7 care are not going to have anyone that would be able to check or enroll. They might contract with an organization that helps them patients get enrolled on their exit, but not likely. So I'd say a good chance, most of the jails in the state are small, a good chance that's not occurring across the board.
Okay.
Theoretically, it could be better in that if the MCOs were in contact with those smaller jails that John describes and were to, let the jails know who is and who isn't, but we're not there yet. So, and it'll probably be a while. Alita, let me ask you a question about your question. Are you saying that to address that gap of 24, 48 hours when somebody gets out who is Medicaid eligible until the pharmacy and the outside providers know that that person's Medicaid has been reinstated, that gap, are you saying that under the voucher system that could fill the gap as long, in other words, if somebody gets a voucher, if somebody's leaving Whatcom County Jail with a voucher, they have Medicaid, their Medicaid hasn't been turned on yet, they show up an hour later in the pharmacy with that voucher and their Medicaid is still technically suspended because that goes through the MCO? Are you saying that the pharmacy, or it goes through a different process, that pharmacy would honor the prescription?
Yeah, so legally, the Medicaid is turned back on once they leave. It's just not showing in the system, is my understanding. So
just to clarify
yeah.
that, so they are let's say they are entitled the moment they step foot on the sidewalk, but the computer system in the sky that would tell the pharmacy that that's the fact, that doesn't tell the pharmacy until 24 to 48 hours later.
Right. So then if you go down my slide here to the billing scenarios, what we're investigating is, so the patient takes the voucher to the pharmacy. The pharmacy has the billing code on there to, in one scenario, bill the healthcare authority. Healthcare authority pays MODA. MODA pays the pharmacy. HCA then has to figure out which managed care plan that patient is on, so who to bill. Then HCA bills the managed care organization that reimburses HCA. So this is just one scenario out there, and that's why it will be good to bring these questions to the reentry advisory group where the MCOs are to, talk about this, because the pharmacy is not going to dispense a medication unless they know they're going to get paid. So we have to figure out who's going to pay this. And so my question on do the jails know which patients are even Medicaid eligible is you can't give a voucher to somebody who's going to walk out and not have Medicaid turned on, because then who's going to pay for that medication?
So what you're saying is that it's no advantage over what currently exists. If the doctor at the jail were to write a prescription, just a plain old-fashioned prescription, and then the patient is on Medicaid, but it hasn't yet been activated in the system, they're in the same boat as if they had a voucher, or is that
If
true?
The person does not have Medicaid and they're not going to walk out and get it turned on, then they need a different way to get a discount. But if your provider writes a prescription on the voucher that's given to them, which has the billing codes on it, and they take it to a pharmacy within an hour of getting out, they're going to get their medication. And
even though the provider one or wherever it is that their status is noted still says suspended.
Yeah. So in the reentry advisory group meeting, the MCOs have said that legally it is turned back on, but in the system it doesn't show yet. So there's this lag time that they can't figure out how to avoid. From, especially if somebody is released in the evening, and then the next day, it's when does the jail enter it? When does the managed care plan get to enter it? So we're trying to fill that gap. It would still be paid for by Medicaid, but they need a way to get it. The pharmacy, if they just pulled up that person under the Medicaid plan, it's going to show that they're not eligible. But the voucher is has all the billing information already on there. So the pharmacy knows they're going to get paid. So they fill it.
Got it. Okay. The voucher has to, when Is the jail is printing out a voucher? Do they have to know which MCO the patient is under?
No, that's the part that I'm saying either HCA has to figure that out once it's in the system. You know, that's the being investigated. But I'm assuming that's going to be HCA then, somebody who or you know, the managed care organizations figure it out. You know, here's the list of people, here's the prescription, go into the system, figure out which plan they're on. So that's to be determined. But
That would be huge if that would fill the gap that people currently have. So that would be huge.
That's definitely a DCYF reentry scenario where I know that HCA has done a tremendous amount of work in terms of that system of activating, and it still does. It's just a, you know, a consequence of a lag in the system where sometimes it isn't turned on, and there may be a gap in being able to fill. And I think also historically a practice where, you know, DCYF has absorbed a lot of prescription costs in the form of, you know, filling a prescription to take with you, that it would make sense to be covered if it's, you know, a release prescription, to be covered and paid for by Medicaid, and a vast majority are leaving Medicaid covered. So.
mm-hmm. So my next question, the second bullet here, is, are all of the Medicaid prescriptions written by a Medicaid provider before the patient goes into jail, or is a provider at the jails writing the prescription? And I ask this because of the Apple Health Preferred Drug List. And if it's a Medicaid provider, then I'm assuming that they are adhering to the Apple Health PDL. If it's a physician within the jail, I don't know that they are paying attention to the Apple Health Preferred Drug List.
To clarify, you're asking about the prescription that the patient leaves the jail with, whether it's written by the jail doctor or the previous doctor before they went into jail?
Yeah. So, you know, was it by a Medicaid provider before they came in? So then that provider would have been aware of the Apple Health Preferred Drug List and would have prescribed a medication that's preferred on that list. Or is there a provider in the jail determining what medication this person should be on? So just starting a medication and choosing one.
So we have three different constituents on this call. We have adult jails, adult and juvenile jail and prison. So let me speak for the adult jails, and then I'll let the others talk about those other two venues. So any prescription somebody's leaving a jail with is going to be written by the jail physician, who is not a Medicaid. I mean, they might also have a second job as a Medicaid provider, and there are some locations where it might be a Medicaid clinic, an FQHC that's providing care in the jail also, but those would be more likely exceptions than the rule. But generally, it's going to be a jail provider who is just a jail provider. Ted, for
It's going to be staff physician at the institution.
so
It will never be a pre-written prescription. Yeah.
Okay.
And there is somebody here from the juvenile jails, I think.
Yep, Ted Bryan from,
Ted, here we are.
I'm the JCA in Thurston County. You know, in most cases, youth come into detention, they have pre-existing conditions, and we work with parents to bring those prescribed medications to kids. A lot of occasions, kids are seen here by contract with a pediatric service, and oftentimes they are provided prescriptions. When kids leave here, we give those to the parents or their legal guardian or the state, whoever's picking them up. So it's a little bit complicated because it's and we don't have anybody here looking into Medicaid. I'm working with another group from HCA on that process. So it's a little complicated, but we never just give kids their meds when they leave.
But if you're giving them, somebody is writing a prescription for that medication, whether you give it to them in hand or not, correct?
Yes.
And
yes,
that person
again,
who's writing the prescription is a doc who you contract with at the facility.
correct.
And that's not necessarily a physician who's practicing, who's a Medicaid physician.
Correct.
Does that, Lita, help you?
Yeah, it does. Okay. All right, and so and then my other question was, do the jails pay for any patient medications when they're leaving? Is that ever a case?
John, you can help here, but I think I would say that varies by jails. There are some that do, and there are some that don't.
Jails are required by RCW to either provide prescriptions in hand, which they pay for, or a prescription in hand to go to the pharmacy for which they pay for. So other options like this are beneficial, I think, if they can get set up.
Okay, so then in that case, the voucher could be paid by the jail.
In some cases, yes. So there could be a patient that's not on Medicaid.
Okay.
Right? The jail would
Okay.
end up having to pay for.
Okay, that's good to know. Okay, so
there's one little carve out that I just want to make sure you and I know the jail folks who are listening appreciate this, that for the carve out would be for medications for opiate use disorder, and while it can happen this way, it's much safer that the patient walk out of the facility with the medications in hand as opposed to a prescription. To reduce overdose risk upon release, and that's different than their antibiotic prescription. And that reflects back to something that William said about the Oregon hospital, and it probably does save some money because some patients don't choose not to fill a prescription, and they have that right. But we know for opiate use MOUD medications that while they have that right, that we can reduce, we think we can reduce overdoses by making sure they leave with the medication.
All right. In this last slide, I wanted to make a case study slide like we had for Department of Corrections and Oregon State Hospital so that ArrayRx can better understand what is needed by the jails. And the purple text here are my guesses at answers just to start the conversation. So you guys can totally delete all this and correct everything on the slide if you want. But just from our conversation today, it sounds like the different jails, depending on, if it's juvenile or adult, et cetera, there's going to be some variations. And the voucher program is customizable for each different facility to meet your needs. But if you can read through here and tell me any differences or, any other thoughts. So, oops, I'm sorry, for the problems and challenges to solve, I put patient care disruption and also costs. Are there other problems or issues that need to be solved?
So just to be clear, when you say patient care disruption, I'm thinking of that as being the Medicaid gap that there's, okay.
Yeah, a gap in they're not going to be able to pick up their medication for a few days or longer. Okay, so then solution, I put a customized voucher program. For enrollment and eligibility, I put that jails would use the MODA's employer dashboard, just like the Oregon State Hospital does. I don't know that jails have the same system that Department of Corrections has.
So recognize that first of all, there is no single jail system. There are
Okay,
58
exactly.
jail systems, plus
Okay,
the juvenile jail, another 20 juvenile jails, and so there is no single system. And I suspect at this point, people probably don't understandably have a good enough idea of what that dashboard
Okay.
looks like, and it may mean, working individually with some folks and saying, oh yeah, that would work. But I don't think after today people would say, oh yeah.
Okay, that makes sense. Okay.
Lita,
Yeah.
I'm gonna jump in. I do
Sure.
want to say, even if you didn't use the employer dashboard, I want, as a common user of the system, the eligibility system is absolutely easy. Even if you defaulted and chose to use the eligibility system where you manually turn people on and off, it's simple. You could have just you don't have to be a clinician. You don't have to be an expert in insurance. Once you train somebody how to use it, it's simple to use. You just have to make sure that you have a process set up to ensure that patients are turned on eligibility and turned off. So I just want to make sure that it's open knowledge that the system that we have access to is easy to use if you choose to go that route.
Thanks, William. Okay, so again, the voucher is customizable, so limitations can be set by each facility for day supply, refills, which drugs or cost limits. The voucher could be used for emergency fills, if you need to run to a local retail pharmacy and get a discount on the drug. And then when the patient's released, it sounds like the voucher could be paid for by Medicaid or by the jail for non-Medicaid patients. And then the result would be consistent coverage of medication to fill that Medicaid gap, manage costs, and help keep them on their medications. I'm starting to go quick because we have 2 minutes. For the next steps, it sounds like it might be good to set up individual meetings with the different jails since each has different needs and see if this can work for you. And I would also like to take some of these questions and the billing issue to the reentry advisory group to talk about how to figure out which Medicaid plan those patients that are Medicaid eligible are on and how that billing is going to work to try and hammer that out.
But to be clear, that sounds really important, Lita. It sounds like that's something that would be transparent to the jails, right? That's something that the MCOs and healthcare authority need to work out behind the scenes. That's not something the jail would need to get involved in. Is that correct?
That's what I'm thinking.
Okay.
Because if it's not turned on and if the jail can't see which plan they're on, then they would just write the voucher and then have it billed to HCA and have either HCA figure out which MCO, etc.
So the bottom line is, if any of these jails or in the adult or juvenile system that are on the line today, if this sounds at all interesting, if you want to save money and help your patients have be able to access medications during those couple of days they get out, or you want less expensive medications that you already provide, but you're getting them, let's say at rack rate at the Rite Aid store, somebody needs a medication, you send the officer in a car, they go pick up the prescription. Any of those scenarios under the ArrayRx, you can get them less expensively. And so if that is of any interest to you, you need to give these guys a call and they will help you set it up. It's that simple, right, Lita?
Yes.
I mean, this is just a wonderful opportunity. I was just so tickled when you and William brought it to our attention. It's just, we may be paying more for medications than we need to, and that's taxpayer money. So
Exactly. Yeah. Yeah. We're a government program, and so we understand the same needs. So the last slide, this is the ArrayRx steering committee. So members from Oregon, Washington, and now Nevada down here in the lower right. Yeah, so please get in touch. Any questions you have. My email is also on the meeting invite.
Thank you so much, you guys, for taking the time to do this presentation for our 3 groups. This is, I know we all appreciate it, and I hope all the institutions will take advantage.
Great. Thank you.
Thanks so much.
Thank you all. Have a great afternoon.
Bye.
Thank you.